just joined us as well. So hi Megan, we've got several of us on the line. I just want to thank everyone very much for coming to our ANZONA webinar. My name's Wendy Drew-Peruzzi and I'm the Publicity Officer of ANZONA and part of the WA chapter with it's actually fairly basic concepts, and that's why I've called it Ortho 101 and going through the different treatment modalities for fractures. We understand a lot of the orthopaedic principles that underpin a lot of practice when we're looking after our orthopaedic patients. Like any time when we're dealing with trauma and when we're dealing with fractures, there's some very, very important things that we keep in mind first, and that is prioritising the management of the patient. Before we even look at our fracture care and think about it, all our ATLS principles must be thought about and maintained. Airway, breathing, circulation will always come first, prioritising the injuries that the patient's got before we even look at some of their limbs or fracture management along the way. Knowing a history, as much as possible, gaining information on the mechanism of injury, because that will, one, tell us about injuries that they might have at the same time, and also tell us a little more about our orthopaedic injuries and give us the level of suspicion that we need to look at what the patient is presenting with. We need to know whether the fractures that we're seeing and the injuries we're seeing are open versus closed, because again, that will differ the way that we prioritise the management of our fractures. Open fractures are going to be much more of an emergency than closed fractures because of that risk of infection. So we need to be dealing with that fairly quickly. Looking at prioritising, of course, the assessment of their neurovascular status. What we're wanting to do is anything that is at risk, we need to know about as soon as we possibly could. When we're talking about open injuries, and particularly open fractures, we need to be identifying, look, does the area require debridement? Quite often our traumas are not happening in nice, clean, sterile environments. It tends to happen out on the road, it's happening out on farms, different areas like that. What we need to be doing is getting washouts, getting contamination, going in and debriding all of those areas before we can really look at definitive fracture management. And that's certainly one of the things we talk about when we talk about damage control orthopedics. Going in, trying to do what we can, and then coming back and definitively managing our fractures a little bit later along the way. And radiological investigations and what's needed to be able to properly be diagnosing our fractures. Obviously, clinical examination is a really vital part and should be what is giving us the level of suspicion, but we use radiological investigations to back up the examination and the assessments that we're doing. Okay, before we look at treating fractures, we'll have a look at what our actual aims are as far as fracture treatment goes. So I've just gone too far on that one. What we're wanting to do with our fractures as much as possible is to be getting good anatomical reduction back of the bones that have been affected. We want stable fixation as our goal to what we're aiming for. We want to try as much as possible to preserve the blood supply to the area, because we can get beautiful alignment, lovely anatomical reduction in our fractures. They can be in a beautiful position for us, but if we haven't had a preserved blood supply, they're not going to do very well along the way for it. One of the classic examples of that is our proximal femur fractures, which are very prone to avascular necrosis. And if we're just putting them nice and back and in alignment, but the blood supply has been damaged to that area, along the track that patient is still not with that fracture healing. As much as possible, what we want to do is early, active and pain-free mobilisation as a goal. When going back around about 20 years ago with our fracture management, or maybe a little bit longer. A lot of our fracture management in orthopedics was about immobilisation of our fractures and immobilising our patients, such as traction. And now what we're doing is we're identifying that early mobilisation, getting patients up, getting them moving, putting forces through the fractures. Obviously, once they've got a stable fixation, is really speeding up all of that healing process. We have things that we know about, including Wolff's Law, which means that the forces that are going through, as far as the gravitational forces that we're putting through when we're actually putting weight through those fractures, is not only helping with the healing, but it's helping that bone reform to the function that it's supposed to be doing. So bones will heal into the gravitational forces and the function that it needs to do. So anatomical reduction is required, particularly if there's significant displacement, if there's angular deformity of the bone ends, or if there's quite a bit of rotation around that area. And as much as we can correct for that within a treatment modality, will certainly assist the healing. So what we want to do is we want to ensure that recovery of the limb function, and we want to prevent delaying or delay degenerative changes that are happening to joints. And if we have that angular deformity, if we've got displacement of the fractures, we're not quite getting that anatomical work, that's where the wear and tear is going to happen along the way and speed up the degenerative changes that are happening. They do have one little saying though, and that's particularly when we're dealing with paediatric patients. You know, as long as the bone ends are in the same postcode vicinity, they're going to heal really quite well with us, with the paediatric patients. And certainly with our paediatric patients, we know that the reduction and the displacement that we can actually get away with is certainly a lot more than what we can with our elderly adults, where all of the bone regeneration is happening at a much, much slower rate. And so because of much quicker healing that we're having with the paediatrics, we do get a little bit of margin of error with them to allow for. Okay, the next thing we want to do is we do want a certain amount of immobilisation for part of the time of the healing, and particularly right in those initial stages after a fracture, we want to be immobilising the bone ends and not allowing too much movement along the way. We do know once our fractures are starting to heal in that initial stage, there's bleeding between the different ends of the bone, and that bleeding allows a little fibrin bridge to come across and start the very, very early part of our fracture healing process. Okay, through that hematoma formation and the fibrin healing bridge, by allowing immobilisation within that stage, we're also allowing that hematoma to stay there, and then for the next lot of cells to come through with our osteoblasts and osteoclasts that are going to first of all clean up the area, and secondly bring the new osteocytes and the new bone cells in. They need to have a certain amount of immobilisation to be able to do that successfully for the fracture healing to continue on. Also, obviously, if we've got a lot of mobility at that fracture area, there's going to be a lot of pain for that patient. We want to try and maintain that anatomical alignment so that when we do get in a good reduction position, we can hold it there. We want to minimise any further injury to a lot of the soft tissue structures around that area. You might have a nice little spike of bone on the ends there that are sitting quite into vascular or nerve supply, and we're not wanting to damage those soft tissues around that area, and just even all the rest of the soft tissues as well that might be damaged through that. And as we first of all said, we want to try and promote that fracture healing in those initial stages, and that hematoma formation is happening really around that 32 hours of the fracture healing. So we want immobilisation for those early stages. Okay, we've got several methods of fracture stabilisation that we can use, that we commonly see, and we'll group them into areas. First of all, there's close reduction. The next one is open reduction and internal fixation to hold that reduction into place. And the third option that we have is external fixation. Close reduction, one of the most common sort of ways that we're seeing a lot of our fracture management happening. Up on the wards, they're not necessarily seeing it quite so much because it's happening in an outpatient setting. It may be happening within the emergency department, people are heading home, or it's happening out in the communities with GPs that they're doing the close reduction. So what it is manual manipulation is used to align the fragments and reduce the fracture. The sort of methods that they're using for that initial part of the immobilisation is via splinting or cast, via traction, which we will see in the clinical area, and we're still actually seeing quite a lot of. It can be done via strapping, for example, with buddy straps within broken fingers, or done by functional bracing. Okay, just some of the examples. The good old plaster of Paris cast is one method of open reduction. And what will be happening is when the cast is being put on, they may be pulling or manipulating the joint. They might be getting the thumbs in and, you know, before they dent the plaster, but certainly when they're putting the soft tissue or the soft parts of the cast on to try and get nice anatomical reduction of that area, holding the limb in a particular position that they know that will be good for that type of fracture. For example, with some forearm fractures, we know what they call the wine glass or the beer position, if Christian would prefer, that holding a hand in that sort of position will assist with the reduction of those types of fractures. So there's really quite an art to the plaster cast and casting of that to get really good anatomical reduction. What we are seeing much more commonly is the use of thermoplastics with the cast now as well. So that instead of plaster of Paris, we're seeing thermoplastic splints used. Good old traction is another way that we use close reduction, and certainly that will be much more in an inpatient setting. And it's just the use of pulling forces and also counter traction to be able to pull a bone into alignment, particularly if we have overriding fragments, for example, a fracture mid-shaft of femur. What we can do is, through the weights and pulleys, provide that pulling force to be allowing for healing and anatomical alignment of those fractures. Different types of splints on different parts of the body that we can use to allow for fracture healing and alignment and protection of the limb. And there's some of the common types we see used of close reduction. Indications for use is fractures that we know that are not involving articular surfaces. So when you start to have a fracture that it goes intra-articular or to within a joint, what we know is this isn't necessarily going to be the best choice of fracture management for it. Once you go into a joint, what we want from surfaces usually is they're best when they're a lovely smooth surface. We know that there's going to be friction and rubbing of that area through movement. So what we're wanting to try and do is to maintain or to correct that articular alignment of the joint. Once a fracture goes into that, it only takes the smallest little lip in that area and you'll get degeneration and wearing of that joint. Okay, so we know in the long term, the intra-articular fractures don't respond quite so well to close reduction. So that might be one of the reasons to go for open reduction and internal fixation of those areas. Simple closed fractures that we know usually respond really well. They will do, for example, fractures around the forearm, again, that are not going into the articular surface. They know respond really quite well out of, following up these fractures for how they have healed. Fractures that have got minimal fracture deformity, they may choose to do. And fractures that we just know through history are not usually unstable following reduction. The advantages of using closed reduction, it's quick and it's nice and safe. You don't have anaesthetic, you don't have surgical time, you don't have all the risks that go with it, and it's a non-invasive approach. Some of the disadvantages are it is immobilising that joint, and quite often will immobilise the joint above the below as well while we're trying to heal it. So it's not allowing for joint movements. You are getting the muscle atrophy and stiffening of those joints while they are immobilised. If there's soft tissue damage or wounds, we're unable to visualise or treat the soft tissue injuries or wounds, particularly when we look at our plaster of Paris. If there's wounds under there, we're not seeing them to be treating them. The other thing with our POPR class, we can control angulation really quite well with them, but we can't necessarily breast in properly for the shortening of the limb. So if there is significant shortening and the bone ends do need to be pulled out, they may look at a different method of treating that fracture. Okay, so we'll move on to the next option that we have, and that's through open reduction and fixation of fractures. Indications, when we can't get good reduction and when it can't be attained or maintained by using closed methods. Okay, sorry, I don't know if you just got a message on the screen then, apologies if you did. Displaced intra-articular fractures, we know again that we've spoken about that. When you get a little bit of a lip in that area, that's when we're looking at degenerative changes along the way. So that's one that they might have as well. In fractures in which closed treatment is known to be ineffective. Okay, proximal hip fractures, we know don't necessarily respond quite so well to closed reduction, although we did used to put patients in traction. Due to the immobility of putting a patient into traction for a proximal femur, we know will be around about 6 to 8 weeks. We know all the complications of immobility that will happen. So that's why now what's happening is they're tending towards open reduction in internal fixation for those fractures. It's also knowing that in some proximal hip fractures, particularly subcapital fractures, there's a really big incidence of the blood supply being knocked off to the femoral head, and due to that risk, we know that it may be better options looking at open reduction, internal fixation, or even a hemiarthroplasty of that area to be done. So if we've sort of followed up the data, looked at the evidence that is surrounding that fracture treatment, and it is shown to be ineffective, what we will do is look at the different options. Okay, epiphyseal fractures or fractures that go into growth plates, we know that they really do need good reduction and that you can't muck around with those fractures. So that may be a reason why they choose to do the open reduction internal fixation, or as we call it in ORF. Fractures that we know have risk of delayed union or have already had delayed union are fractures of long bones. Okay, because there's a lot of rotational forces on those areas, what we need to do is think about what are the outcomes along the way with those fractures. Some bones will respond a little bit better to the rotational forces and even a little bit of shortening of those areas. Some other areas, such as the tibia, we know because it's got a hinge joint above and below, we really don't have any margin of error for that to overcome that if, once we're returning patients back to mobility. So with those fractures, we will go for the ORF. The other thing is pathological fractures, whether it's through malignancies, where we know that maybe being able to offer an ORF will actually offer those patients a degree of pain control as well, that we may look at. Usually it comes back to there is quite different thinking that is coming through, and one of the areas that I will highlight is our humeral head fractures. Okay, we do know that quite often patients with pathological fracture through the area of, sorry, I'll come back to that. Sorry, through osteoporotic fractures of your humeral head, we know that there is a poor blood supply. Sometimes our elderly patients are doing really, several part fractures, but we know that the blood supply has been knocked off to that area. However, they are now moving towards decisions about, do we do off of those fractures? Do we do close reduction? And what it is why there is controversy of that area is what sort of function are they able to give back to those patients? So, there is quite a bit of controversy about that as to what is the best way of going to go with that and what is the gold standard, even though we know it's a pathological fracture of that area. Okay, that's probably a whole talk in itself, so I won't go into too much details on that one. With those contraindications, if there's a presence of an infection, we're not necessarily wanting to put nail screws, all those sort of things. Putting metal into that area where there's already infection will lead to poor outcomes. If there's severe comminution and if that fracture is in lots of different fragments, it's very, very difficult for them to piece that back together and try and maintain alignment of that area just through using plates or nails in that area. Sorry, just having a bit of water. So what they may do is look at third option, which is external fixation. If there's severe disruption of the soft tissues, particularly with our open fractures and particularly with our high-grade, high trauma open fractures, for example, tibial fractures where we have quite a degree of bone on view, we know putting a plate, putting a nail in that area, the outcomes are really not going to be too good for that thing. So what we may do is look at the third option as well. Again, it really needs a good blood supply. It really needs a nice tissue envelope that's around that area to allow for that healing to happen. So you can play, you can get it beautifully back together. Doesn't mean that area is for you if you haven't got good blood supply and a lovely even fast and soft tissues to be allowed that healing to take place. Okay, just a few of the examples. We have a look at some of the methods we might see is by using all sorts of metalwork, and it's things like wires and pins, plates, screws, tension band wiring, and also nails. Okay, so they have nails and cutlery that they use their work. Okay, as we can see here, we've got screws on the right hand side with the medial malleolus and plates on the left there holding things together. So when we look at this X-ray, I just want to sort of point something out when it's intra-articular versus extra-articular. And with the arrow here, okay, on this side we have we have the medial malleolus. Can we see medial malleolus fractures of that? More often than not, what we will see is open reduction in the internal fixation time. Listen, maybe much of that, something's right into that intra-articular joint, and because that's up
breaking up a little bit. Well, there's not there. It's the same for other people.
Okay, sorry.
It's probably your internet connection. That's what it sounds like. Are you
got
on wireless or?
Yes, I am on wireless. But could you just give me 1 minute?
Is it possible if you
I'm just going to double check on it. Okay. Right, I'll just need 1 minute to see if this is something that I can show you, and I'll come straight back. Okay. Just chat amongst yourself.
Sounds good. So yes, when you might be using wireless, which might be struggling to translate in the pictures as well. So yeah, sound bad for you guys. So I think it's a internet access struggling a bit. So is my sound coming through okay? Yep, cool. Yeah, so I'll probably use that per end, unfortunately.
Okay, I'm back. Hopefully that's a little bit better now.
Yeah, that sounds really good actually.
Right, how's that going? Rightio, just back to that medial malleolus, where I've got our little pencil here. Okay, we can see that the articular surface there goes into that joint. So if we were not getting a nice articulating surface nice and smooth on that area, that would be going on to degenerative changes. Okay, the other type of ankle fracture that we see is on this lateral side, okay, which is part of our fibula. Okay, this would also be called a malleolar fracture, lateral malleolus. We can see down on that distal end, yep, that's all part of the joint there and intra-articular, but all of this area here is not in contact with the joint. It's more sort of a fibular fracture, but you may hear it called a, malleolar fracture as well. We know that chances are that will respond really quite well to close reduction. So they may be just casting that area on that side. The other thing we know with the fibula is it heals really traditionally quite well. So that's why medial malleolus may end, some of the ankle fractures may get the ORIF done. Other ankle fractures may be close reduced. Okay, I hope that makes sense. Okay, with proximal hip fractures, what we're having a look at here is one of the types of dynamic hip screw with your Richards pin and plate. Again, we know, depending on which level of the fracture is how well that area is going to heal. As we say, close reduction may not be the best for that area because of the blood supply being disrupted to the femoral head. So that's why quite often it's open reduction, internal fixation, or even the hemiarthroplasty that's done. Tension band wiring, here's one example of it for a patella fracture. Okay, because of the lovely, nice strong quads that we've got, our patella sits within the quadriceps tendon coming down and connecting onto the tibia. And so if we've had a fracture straight across, okay, and the two poles are apart, what they may choose to do is use some tension band wiring, hold those two poles together so that when there's contraction of the quadriceps, we're not pulling apart the patella. Okay, and just a tibial nail example there for you. So open reduction, internal fixation, some of the advantages is that if we do get, good alignment and good reduction on that and the surgeons are happy, we can start mobilizing those really quite early, getting some weight through, maintaining some of the muscles, getting a little bit less atrophy, but also those gravitational forces and, that weight coming through is actually stimulating all of that healing taking place a lot quicker. We get restoration of the anatomical shape of the bone, shorter hospital stay when you compare it to something like traction, so that patients can, be out of the hospital nice and quickly for their good as well. Disadvantages are that it is invasive when you compare it to close reduction. It does require theatre and also anaesthesia. And like any time when there is an intervention like that, there is a risk of infection. Okay, so our third type and our third choice along the way is external fixation. Where we're seeing this use is some of the indications might be for a severe soft tissue injury. Okay, the tibia is one that comes straight to mind with that as well, and it's one of the ones that we do commonly see in orthopedics. We see some really nasty injuries of that region. Open fractures as well that we may see to try and correct some of the deformities and Iliazarov frames, and we'll show you an Iliazarov in a second, really has opened up quite a world of the sort of deformities and the sort of areas that we can now have a go at healing within orthopedics. Segmental comminuted fractures, so ones that are in several pieces, is something that we can use the pins of the external fixation and, try and hold those together really quite well. Areas or segment of bone loss, okay, so there can actually be, by the time that you've gone in and debrided all of the bone that's been devitalized in a really nasty injury, there can be quite a degree of bone loss. And so what can happen is through the external fixation now, we can try and regenerate and help with the bone loss within that area through the distraction of external fixation, right when our fractures are at that nice sticky sort of healing phase, to be allowing for that osteogenesis to be used to bring bones back out to length, to be healing them. And they're particularly handy in the presence of infection, because what can happen is the different pins can be used away from the areas of either injury or areas of infection to still hold our fracture fragments together for us, but being nice and free and not having metalwork right against that infection or that contaminated, infected area. And this is a classic example here, when how you can see that it will work is in this very initial stage of what is a really, really nasty, been a very nasty soft tissue injury over the tibia. We can see that we've got bone on view here through the tibia. We wouldn't want to have a plate or a nail in that area, because we would be setting that limb up for much worse infection, and we'd be setting that one up to fail. So what can happen is, in that emergency stage, they can bring the pins in just to be a little bit away from those areas. We can still immobilize that area, and we've got access to that injury zone to be prioritizing, the management of those soft tissues, because that obviously needs to be managed before we can go in and try and manage that fracture. There's been at least one go at debriding all of this area, and part of that emergency management would have been the trying to get rid of as much contamination, trying to get rid of as much devitalized tissue as we can. Then what they usually do is bring one of those patients up to the ward, and we watch and we wait on this injury. Obviously, there would be a lot of systemic antibiotics going on at the same time of this injury. And while they're watching and waiting, usually debridement may take 2 or 3 different goes. What we can see is that that injury might have shown all of this area as initially being really quite devitalized, and they've debrided it. As they're waiting a couple of little days, that zone of injury, just through where I'm sort of showing you there, is going to show themselves a little bit more. And we can see that that's more tissue that has been injured and probably not getting a blood supply, and it's showing itself as damaged tissue. The orthopedic surgeons would be taking that back into theatre for a second look and a second go, and they would be more than not likely debriding a whole lot bigger area of that. Again, bringing it back up to your clinical area, lots of systemic antibiotics, watching and waiting just to see if any more devitalized tissue is going to show itself along the way. And we've got to go through that process first before we even really think about fracture management and, trying to heal all of those tissues. We want to get rid of the tissue that's damaged first to really have a go at saving that limb. Okay, different type of external fixator, and this is the Iliazarov frame. And when we have areas of bone loss, particularly if there's been a segmental or quite comminuted fracture, maybe they've gone in and removed all of the areas again that are not really viable for that area. And then once the fracture healing is starting to take place, just by winding these little pins, what can happen is that bone can be distracted out and we can gain length. Okay, they can either gain length, they can do angular corrections of that area, and it's really quite a clever device. Okay, I was involved with a case a few years ago where a gentleman on a farm had put his leg into mushroom auger by accident, and by the time it was all debrided from the area of damage from his femur, he'd actually lost 20 centimetres of his femur. Usually, you would think that by losing 20 centimetres, you'd be thinking of amputation, but through an Ileozarov frame and a good 2 years of management, they were able to bring that limb out to length and correct for the 20 centimetres. Finally, were able to get his foot down on the floor, and after about 2.5 years, he was able to start mobilising. Okay, so there's some really incredible things that you can now do with the Ileozarov frames that would have led to amputation before the availability of that as well. Okay, the next one is really quite an old slide, and it's quite an old types of fixation, but it was just quite a good illustration of also how external fixators can be used in the first aid part of the process as well, or the initial, ATLS principles of maintaining patient circulation. Okay, and this is someone that's had a really quite nasty femur fracture. There's a lot of blood loss through all of their pelvic area, and through external fixation is one of the areas that you can look at by providing pressure to put pressure onto that bleeding of the area. More likely than not, you're going to be actually seeing pelvic binders that are available to do that, or C-clamps, or there's quite a few different ways to do it. But certainly, it was a good part of holding the pelvis together in the initial management as well. Okay, so external fixation is really quite advantageous now for our fracture management. It provides us with a rigid fixation. It allows direct visualization and access to wounds and soft tissue damage that might be prioritised in healing. It allows concurrences and also allows us access to the soft tissues. In some cases, what it will allow is early patient mobility, and it's suitable for use within infected, acute, and also non-union fractures. And certainly with the Ileozarov, some of the non-union tibial fractures that haven't responded well to other means have responded quite well to external fixation as an option. Disadvantages are, just like anything with pins, there is a risk of pin tract infection. It is invasive. It can be really quite uncomfortable to have one of those frames on, particularly above the knee, and with femur fractures, it is quite a difficult thing for patients to sit down and to be comfortable with it. There's also the appearance of the device as well. You look at halo vests and halo traction and people walking around when they can out in the community, and certainly there is that appearance of the device, but obviously it's doing a really good job for the purpose that it's required. Okay, so really to sum up, what we're aiming for, whichever treatment modality that we're using, is good anatomical reduction and immobilisation of our fractures, which are going to try and promote optimal healing and return to function as soon as possible for those patients. The three types that we usually see in orthopaedics is through closed reduction. We see open reduction and internal fixation, or otherwise known as ORF, and external fixation also provides another really quite good option within our fracture management in orthopaedics. And now my shameless plug is just to let you know, in October 2017, we have our next ANZONA conference. We're hosting it over here in Perth, Western Australia, and the dates are the 25th to the 27th of October. We would love to see you guys over here and make you welcome. And I just encourage you to, first of all, join us, or second of all, please contact us and let us know, how we can assist you. Maybe you'd like to come and see a clinical area within Perth, and we'll try and facilitate that for you as well. And Paul's just put our website up, which is anzonaconference.net, where you can put expressions of interests in. The other thing is our call for papers is now open, and we'd love you to come and share, what you're doing in your clinical areas as well. So we'd love to see you in Perth, and thanks everybody for joining us for the presentation. What I'll do is I'll open the chat to any questions on what we've covered today.
Thanks, Wendy. That was really good. I think it's important to, as an orthodontist, to get a sense of how fractures are treated, what the sort of methods, because that has implications sometimes quite seriously for restrictions to mobility or range or weight bearing, all those sorts of things. So it is, I think it's really useful to have a sense of, okay, what sort of fracture is it and what has it involved? Is it involved joint? How stable is it and how is it being fixed, as to then, okay, what can the patient then do? So that's really interesting. Is there any other questions, Scott? Fast typers.
Yeah, but someone talking at the minute.
You're typing right. It doesn't look like it. So if there's not any questions, I'll just wait for asking what.
Okay, what are we using for site?
Yeah,
okay, what I would say, Mariana, is looking at the evidence-based practice, and the best thing that I can actually direct you to would be some of the work that Julie Santee Tomlinson has been doing, because I think it's something she's researched at PhD level, so I think she can offer a lot better opinion than I can on that one. So if you look at the International Journal of Orthopaedic Nursing and Trauma, that would actually be the area that I would point you to. Also, Cochrane, because Cochrane have got a Pinsight care policy as well. Yeah, and as Christian says, take care. It is Pinsight care is a can of worms. Okay, I'm currently not working on a specific clinical area, and I must say it is something that I would be able to tell you that I have seen used, but I don't think I've got the authority compared to those others to really say. I think Julie's work would be much more evidence-based than what I could answer on that one. Yeah, it is a can of worms as well. I think it comes down to your principles of management too, so that all of our good orthopaedic principles being maintained would be what I look at. But I might just step out on that one, and yeah, I think Paul's just put up some of the work
that's a little
by
bit
the
older
Royal
than
College of Nursing.
Yeah, that's 2011, I think, from memory. I'm pretty sure there's been an update for that. If you search for, I think it's through the RCN, it should still be there, because the UK group, when they do this work, they have to publish it through there. Pretty much all the research on pin sites is really, well, I've seen some primary studies that are pretty small, not overly well designed, but there are a number of bigger papers, but really a lot of them are based on consensus care rather than actual randomized control trial or something like that.
Yeah.
So again, it's not fabulous evidence, but at least there's a bit of information out there.
Yeah, that's right. And it's probably one of the areas that really highlights that orthopedic nurses, we really do need to be getting into a little bit more research and looking at some of the just basics that underpin a lot of our orthopedic care, and getting that evidence-based work behind us. And so I'm sorry if I've sidestepped that answer, but I just think that there's people that are more authority than I am to answer that one. And Christian, yep, we'll see you in October. That sounds good. I look forward to it.
All right, looks like that's all the questions. So thank you all for coming along. Thank you, Wendy, for presenting and preparing the presentation. We hope to have another one in maybe a month. Is that right, Wendy?
Yeah, yep, that's right. That's right. So in about a month's time, for the people that are on Facebook, that's a really good way of keeping in touch with what we're doing with ANZONA. And we're also on Twitter now as well at ANZONA1. And we keep lots of updates for things like when our webinars are. Okay, so thanks very much, everybody.
And also, all the webinars get added to YouTube, but we then put links to them in the ANZONA website. So if you need to listen to this one or others, you can access them through the ANZONA website and listen to the recordings as well. Okay, thank you all.
Okay, thanks very much. Do you want me to kick it off?